everyone, and welcome to today's webinar. Thank you for joining. My name is Trudy McKenna, and I am the Director of Medical Education at Natera. We are so honored to introduce Dr. Larry Greenbaum, who will present this webinar entitled Genetic Testing in Pediatric Nephrology, Tubular Disorders. Dr. Greenbaum, MD, PhD, is the Division Director of Pediatric Nephrology and the Bernard Marcus Professor of Pediatric Nephrology at the Emory School of Medicine and Children's Healthcare of Atlanta. He has also served as the President of the American Society of Pediatric Nephrology and as Chair of the Executive Committee of the American Academy of Pediatric Sections on Nephrology. With that, I will turn it over to you, Dr. Greenbaum.
Great. Thank you so much, Trudy. I appreciate the introduction. I'm really delighted to be with you today talking about genetic testing. I was reflecting back on when I started my career, there were very few pediatric kidney disorders that we could do genetic testing on, and it was pretty unusual. Gradually over the years, there were more and more diseases where a specific genetic locus was identified, and you could potentially do genetic testing, but there were a lot of barriers. That genetic testing was very expensive, and it tended to be, you could test one gene for $4,000, and if that was negative, then you'd move on to the next gene. So it was really a lot of barriers, and there weren't that many genes. And what's really been exciting over the last 10 years, I'm sure you're all well aware of this, is that there are now literally hundreds of genes identified that cause pediatric kidney disease. And even more exciting, over the last few years, computers have grown up in capacity every few years. They triple or quadruple their capacity. The cost of genetic testing has gone down quite dramatically and has enabled it to become affordable. And really over the last few years, at least in our practice, we've been able to do a whole lot more genetic testing than we've ever done before. And this has really, really, I think, improved the quality of care that we're able to provide to pediatric nephrology patients. And so what I'd like to do today is really maybe give you a flavor for how genetic testing can be useful in your practice, and give you some practical tips about the approaches that we've used to who to do genetic testing on and how to do it in an efficient manner so that you can incorporate it into your practice. I need to advance my slide, and just so you're aware, I am a consultant for Natera, who's sponsoring this webinar. And the basic outline today is we're going to go through genetic testing in children with kidney disease. And what I'm going to do is review a few studies that really illustrate, I believe, some of the power of genetic testing in a variety of different clinical situations. Then we're going to discuss about, who do we get genetic testing on these days? And at least I'll share with you our practice. We have some very defined protocols with certain conditions about who we do testing on and who we don't. Then I'm going to go through some case presentations. I have 5 case presentations. Some of them are nothing all that exciting, and some of them are some pretty interesting cases, I think, and illustrate some challenges in genetic testing. And finally, I'm going to go through how we've made genetic testing work efficiently in our clinical practice so that we can talk to the patient about it and get it done in an efficient manner, and it doesn't, the actual process of getting it done doesn't become a barrier to doing genetic testing. So what I'm going to do now, as I promised, is just review some data from the literature on the yield of genetic testing in a variety of conditions. I'm going to start out with nephrotic syndrome, and then we're going to move through some other conditions. But I think with all of these, it's very important to remember that there's a certain amount of selection bias in these reports. And I've only taken a few reports from the literature. I could have taken many more, but I just wanted to give you a flavor for things. But there is a lot of selection bias. One set of selection bias is that the people who tend to enter these studies are maybe patients that have a higher likelihood of having a genetic disorder, because there might be a history of familial disease. They may have more severe disease. So there may be a little bit of selection bias for a higher yield. On the other hand, a lot of these studies were done with more limited genetic panels than we have nowadays. And so they weren't screening as many genes as we are able to now. So they may have had a lower yield than we are seeing today. So one of the exciting things I think that we're going to be able to do in the next 5 or 10 years is really find out what is the yield of genetic disorders in different clinical situations in our practices. But I think it's pretty clear that for a lot of conditions, it's pretty high. So let's start out with nephrotic syndrome. This is a study that was done by an Italian group looking at children with nephrotic syndrome. And they looked at children with steroid-sensitive disease and steroid-resistant disease. And this is probably not a surprise to many of you, but the children with steroid-sensitive disease, there were no genetic variants detected. And that's really pretty consistent throughout the literature. But in the steroid-resistant patients, and they had 64 of those in this study, 30% of them had variants in what they called podocytopathy genes. So these are genes that classically most are best known for causing nephrotic syndrome. And you can see that podosin NPHS2 gene was clearly the most common in this Italian study, European study, not very surprising, but a variety of other genes had variants in them that were causing nephrotic syndrome in these patients. So 30% had these podocytopathy gene variants. But what was interesting is when they looked at other genetic variants, they found variants in what they called syndromic genes. And these were not patients that, had Alport syndrome and they did genetic testing on them. These were patients that had nephrotic syndrome. They were thought to have just plain old nephrotic syndrome. There was no suspicion of Alport syndrome or Dent disease or Fabry disease. And lo and behold, they found these other diagnoses. It's been very well reported in the literature how commonly Alport syndrome gene variants are responsible for nephrotic syndrome. And that was the most common in this study. But they also found Dent disease, which other people have described, Fabry disease, even a patient with cystinosis, and a number of other what we call syndromic disorders. So all told, they found a really high yield of genetic variants accounting for nephrotic syndrome in patients with steroid-resistant disease. And we'll do one other study. This is a study from the wonderful work of Friedhelm Hildebrandt, who's done some of the amazing work in genetic variants in pediatric and adult kidney disease for that matter. And this was a large international cohort and looking at steroid-resistant nephrotic syndrome. And they found close to 30% of the patients had variants. Again, NPHS2 was the most common. Now they looked at children less than a year of age, unlike the previous study. So they had a very high yield, as you can see in the figure, in the younger children, 0 to 3 months and 4 to 12 months, almost 70%, 50%, and lower yields as they got older in age, but still a fairly significant number of patients who had a genetic explanation for their nephrotic syndrome. And again, this was only looking at 27 genes, and clearly the number of genes has expanded since this work was done and published 6 years ago. So you can imagine the yield nowadays would certainly be higher. But again, there was a little bit of selection for some of these younger patients, and also there may have been a little bit of selection bias for patients with known familial disease. So what do we do in terms of nephrotic syndrome? The advantage of doing genetic testing is that by and large, these patients who have genetic variants do not respond to immunosuppressive therapy. So there's a huge benefit for making this diagnosis because you can prevent these patients from receiving these toxic immunosuppressive medications. We also know clinically almost none of them recur post-transplant, so that's very helpful in their management. You're not putting catheters in to do plasmapheresis. You're not worried about post-transplant recurrence if you know they have a genetic etiology. And of course, once you have the genetic etiology, that may provide important prognostic information because you can look at other patients with nephrotic syndrome and Alport syndrome, etc. And then a number of these disorders that I've described that were found to cause nephrotic syndrome require other types of therapy. Cystinosis, Fabry disease, Dent disease, all potentially require other therapies, not immunosuppressive therapies, but other therapies that I'm sure most of you are quite aware of. And occasionally you even find a patient who has a treatment responsive form of nephrotic syndrome, for example, variants that are in the mitochondrial pathway where they may benefit from coenzyme Q10 therapy, and there's been a number of such disorders described. So you may in fact discover a patient who you can cure of their nephrotic syndrome by putting them on therapy. So that really has tremendous benefits in making the diagnosis. Next, we'll move on to kidney stones. This is another area where we now know that a fairly high percentage of our pediatric patients with kidney stones have a genetic explanation for their kidney stones. This is, again, a nice study from Professor Hildebrandt. They took patients from a standard stone clinic. Again, it's possible that there's a little bit of referral bias, but these were a standard stone clinic, so not selecting for patients that were suspected of having genetic disorders. And they screened for 30 genes. Again, there are more genes available nowadays than there were 6 years ago. And what they found was in pediatric patients, 20.8% of them had variants in genes explaining their kidney stone disease. In the adult patients, it was 11.4%. And you can see here in the pediatric patients, it really didn't vary all that much by age. It was anywhere from a little less than 20% to a little bit below 30% with a genetic explanation of their kidney stone disease. And I should point out that 5.8% of these patients had nephrocalcinosis, which increased the risk of having a genetic explanation for their, quote, kidney stone disease. The next topic is CAKUT, or congenital anomalies of the kidney and urinary tract. And then this is another study from Dr. Hildebrandt. Again, he's done some of the best work in this area. And this was looking at 17 dominant causes of CAKUT. And they took patients with just VUR, patients with kidney hypodysplasia, patients with unilateral agenesis. So real wide range of patients with CAKUT. And they found 6.3% of them had gene mutations explaining their congenital anomalies of the kidney and urinary tract. Again, demonstrating that if you look for it, you will find it. The next category that we're going to look at is tubular disorders. And it's probably not a big surprise to many of you that there are not a lot of non-genetic causes of tubular disorders in children. The secondary forms that are more common in adults, we don't see very much in kids in general. And so one would expect a fairly high rate of a genetic explanation. They looked at 37 genes in 384 index patients. And again, this was published in 2018. They left out a number of genes that one would include nowadays. So their yield would probably have been higher. But they found genetic mutations in 64% of their patients. And in 16 of their patients, it would actually change the clinical diagnosis. And we'll show that to you in the next couple of slides. So these are the tubular disorders that they were looking at. So there were, for example, 174 patients who had a diagnosis of either Bartter syndrome or Gittleman syndrome. And they found a genetic explanation in 74% of those patients. The other common disorders you can see here: pseudohypoaldosteronism type 1, distal RTA, nephrogenic DI, Dent disease, infantile hypercalcemia, nephrocalcinosis, and hypercalciuria, not a specific disorder, but a clinical presentation. Those were the more common clinical diagnoses, and you can see the yield range depending on the clinical diagnosis, but overall was quite high and close to 70% as a group. And these are the patients where the clinical diagnosis was different from the genetic diagnosis. There was a large group that was Gittleman syndrome, but really clinically, but was really Bartter syndrome genetically, and another group that was diagnosed with Bartter syndrome clinically, but was in fact Gittleman syndrome genetically. Not, a major effect on treatment and management, but it's always nice to know what you're treating. But what was interesting was a whole group of patients where they really changed the clinical diagnosis in a substantial way, changed the genetic diagnosis in a way that would really change your management potentially in patients. So you went from Gittleman syndrome to an HNF1 beta mutation, which has a very significant prognostic and hereditary implications for the patient and the family. You went from dense disease to distal RTA. You went from, a very clinical diagnosis, hypokalemia, to distal RTA, and then all of the patients that had this nebulous diagnosis of nephrocalcinosis were in fact genotyped and found to have a hereditary cause of their nephrocalcinosis. So the genetic testing in a number of patients was really very useful in terms of affecting patient management.